Welcome to the Deep Dive Ortho. We're the show dedicated to, well, unraveling those complex clinical challenges and giving you, medical professionals, some really actionable insights. Today, we're diving into something that I think for many of us can feel like a bit of a clinical chameleon. We're talking about that persistent, ulnar-sided wrist pain, often with that really perplexing snapping feeling. It's a complaint that, frequently leaves patients quite frustrated, and it can mask some surprisingly intricate underlying issues. We're focusing, of course, on the extensor Carpi Ulnaris tendon, the ECU, and its associated problems. It's a critical structure, integral to wrist function, but sometimes, well, highly problematic. So our mission today is pretty clear: to equip you with a practical, nuanced understanding, something that will genuinely enhance your diagnostic precision, your management strategies for ulnar-sided wrist pain, and ultimately benefit your practice and, well, most importantly, your patients. And joining me to navigate this fascinating and often tricky topic is a real authority in the field. His extensive expertise in orthopedics and hand surgery makes him the perfect guide for this insightful evidence-based discussion.
Thank you. It's a pleasure to be here. I'm certainly looking forward to delving into the nuances of ECU pathology. It's a really intriguing area and perhaps more common than many might initially believe.
Great. So let's start by laying down the foundations, the sort of blueprint for this deep dive. The ECU tendon itself, we all know it's on the pinky finger side of the wrist.
Mm.
But could you maybe elaborate on its precise anatomical journey and its fundamental nature? How does it fit into the mechanics of the wrist?
Absolutely. The extensor carpi ulnaris tendon is, well, it's a crucial structure, no doubt about it. It actually originates quite proximally
Right.
from the lateral epicondyle of the humerus.
Right.
That's the bony bit on the outside of your elbow, and also from the posterior border of the ulna. That's the long bone running down the back of your forearm on the little finger side. From there, it travels down the forearm, crosses the wrist joint, and then finally inserts onto the medial aspect of the base of the fifth metacarpal, right at the base of the little finger. Structurally, well, it's a fibrous connective tissue. Think of it like a robust rope, yes, but a highly dynamic one. Its main job is to transmit the force from the ECU muscle, attaching it firmly to the bone to, make movement happen. And it's important to remember, the ECU is just one of 6 major tendons in the forearm. They all work together in concert, really, to control all those intricate movements of the hand, wrist, and fingers. Understanding this exact path is, I think, the first step, because any disruption along this course can lead to the problems we're going to discuss.
That detailed journey really does help visualize it. Okay, so given its path and what it's made of, what are the ECU's primary biomechanical jobs? And how does it team up with other tendons for wrist movement and function?
Its main actions are quite distinct. It helps with wrist extension, bending the wrist backward, and also ulnar deviation. That's moving the hand towards the pinky side, adduction. But where it gets really interesting, and actually often where some diagnostic confusion can creep in, is its synergistic function. The ECU, you see, very rarely works completely on its own.
Ah, okay.
For instance, it teams up with the extensor carpi radialis longus and brevis to get a balanced extension of the wrist. So it stops unwanted radial deviation as you extend. And similarly, for pure adduction or ulnar deviation, without bending the wrist forwards or backwards, it works powerfully with the flexor carpi ulnaris, which is on the opposite side of the wrist.
Right, a balancing act.
Exactly. This combined action is absolutely critical for many high-power activities. Things like powerfully clenching your fist, making a strong power grip, hammering something, throwing a ball, or even, a golf swing. Think about the amount of force transferred through the wrist in those actions.
Huge amounts.
Immense. And beyond just movement, it also contributes significantly to the stability of 2 really vital joints: the distal radial joint, the DRUJ, and the ulnocarpal joint. So if you're assessing ulnar-sided wrist pain, you have to remember that ECU isn't just about movement. It's a core stabilizer, too. Missing that dual function is, I think, a common diagnostic pitfall.
That's a really crucial point, that dual role, movement and stability. And speaking of stability, I know one area that often seems to be a bit of a blind spot for clinicians, maybe myself included sometimes, is the ECU subsheath. Could you shed some light on its critical role, especially its sort of unique anatomical relationship?
Indeed. And this is a critical anatomical detail. It directly impacts the pathology, and it's a point of, well, frequent misunderstanding. The ECU tendon is stabilized within its groove on the ulna by a unique fibro-osseous subsheath. It's vital to clarify that this subsheath lies inferior underneath the main extensor retinaculum.
Right, deeper.
Exactly. The extensor retinaculum itself, despite looking quite broad, doesn't actually provide direct ECU stabilization. It attaches to the pisiform and triquetrum, not directly to the ulna where the ECU really needs that confinement. Some recent cadaveric studies actually suggest the proximal half of this subsheath is particularly significant for dynamic stability.
Yeah.
It highlights a specific region of vulnerability, really, where tears are most likely to happen. So the critical takeaway here is, if you're thinking about stability issues, your focus needs to be squarely on this subsheath, not the more superficial extensor retinaculum. It's the difference between looking at the main anchor line versus maybe a decorative rope on a ship.
That makes the distinction crystal clear. Okay, now with that unique stabilization in mind, how does the ECU tendon's position and tension actually shift with different forearm and wrist movements? And why is this dynamic behavior so relevant to potential injury?
This is where we really start to understand the mechanisms of injury, why certain activities seem to predispose patients to ECU issues. The ECU tendon's position, its tension. They are highly dependent on specific wrist and forearm movements. Consider this. In supination, turning your palm up, like holding a bowl of soup, the tendon lies more dorsal, towards the back, relative to the wrist's center of rotation.
Okay.
This position enhances its leverage, making it a stronger extensor in that particular position. Conversely, when the forearm moves into pronation palm down, like turning a doorknob, the tendon shifts more palmar and ulnar,
Right.
which actually diminishes its contribution to extension. This positional change is directly linked to its angulation as it exits that subsheath. In supination, the tendon exits the subsheath at roughly a 30-degree angle. However, in pronation, it exits in a more longitudinal straight-on direction, reducing that angle.
So more angled in supination.
Exactly. And this increased angulation you see in supination, especially when you combine it with wrist flexion and ulnar deviation, well, that places considerably greater tension on the subsheath. It's almost like a constant low-grade stress test on that stabilizing structure. This mechanical stress predisposes the subsheath to injury during forceful movements in these positions. It explains why certain athletic actions, like a golf swing or a tennis serve, can be so damaging to this particular structure.
That insight into its angulation and supination really makes sense of why certain movements are so damaging. It is like a constant stress test. So with that in mind, just to round out our foundational understanding, could you briefly touch upon the nerve supply and blood supply of the ECU?
Of course. Understanding its neural and blood supply is, well, essential for a complete anatomical picture. The ECU gets its nerve supply from the posterior interosseous nerve. That comes from the deep division of the radial nerve, carrying nerve fibers for the C7 and C8 spinal roots. This is important to consider if you're evaluating maybe a more diffuse pain pattern or perhaps some neural involvement.
Right.
In terms of blood supply, the arterial supply, it receives blood from branches of the radial recurrent artery and the posterior interosseous artery.
Yeah.
Now, these details might seem brief in isolation, but knowing them provides the full picture. It forms the bedrock, really, for diagnosing and treating ECU pathologies effectively.
Okay, with that really comprehensive anatomical and biomechanical foundation set, let's move on to the common painful conditions that affect the ECU. Many of us have definitely encountered cases of ECU tendinitis. How would you define ECU tendinitis, and what does its typical clinical picture look like in your practice?
Right, ECU tendinitis. At its core, it's an inflammatory condition. It affects the extensor carpi ulnaris tendon and often its surrounding sheath, the tenosynovium. It's actually quite commonly seen in non-athletes, perhaps someone who started a new repetitive hobby or job task. And it often presents without a clear, obvious traumatic incident, which can make the history a bit less straightforward sometimes. However, it's worth noting, it can also crop up following a wrist fracture, maybe as a secondary complication due to altered wrist mechanics or perhaps prolonged demobilization.
Okay. And the clinical picture, what are the diagnostic clues?
When we look at the clinical picture, the diagnostic indicators, several symptoms tend to stand out. Patients typically report tenderness directly over the ECU tendon itself, particularly as it runs over the distal ulna. You might also feel on palpation some localized swelling, or maybe a feeling of fullness within the tendon sheath, almost like a distinct sort of rope-like thickening sometimes. A classic sign is crepitus, that palpable or sometimes even audible grating sensation. That can occur with wrist movement, particularly on extension or ulnar deviation.
That grating, yeah.
And a strong indicator is pain brought on by resisted ulnar deviation of the wrist, asking the patient to point their hand towards a little finger side against resistance, or perhaps resisted extension whilst in ulnar deviation.
And imaging, what role does it play here?
For diagnosis, plain radiographs, your standard x-rays, are generally unremarkable in cases of just isolated tendinitis. Their main role is really to rule out other things, occult fractures, wrist arthritis, or maybe changes to the distal ulna itself.
Yeah.
MRI, magnetic resonance imaging, might show some fluid accumulation around the tendon, which is consistent with tenosynovitis or inflammation. And sometimes you see thickening or signal change within the tendon substance itself, suggesting tendinopathy.
Right.
A practical diagnostic test you can do in the clinic, especially if you're trying to really pinpoint the pain source, involves injecting a small amount of local anesthetic, like lidocaine, around the tendon. If the pain resolves significantly after this injection, well, that strongly suggests the ECU tendon is indeed the primary source of the patient's discomfort.
That's a very clear breakdown of tendinitis.
Yeah.
Now, let's move on to what can be, well, a more dynamic and, frankly, often more challenging condition to diagnose: ECU snapping or subluxation. How did this condition manifest, and what's the underlying problem, the pathophysiology of this instability that causes so much grief?
Right, ECU snapping, or subluxation. This describes a condition where the ECU tendon essentially loses its normal anatomical position. It slides in and out of its stabilizing groove on the side of the wrist. It's basically a breach in the integrity of that critical subsheath we discussed earlier. It leads to that characteristic, often painful, popping or snapping sensation patients describe.
So the sheath is damaged.
Precisely. The root cause of this instability is typically a disruption, or perhaps just attenuation, thinning, of the ECU subsheath, that primary structure that normally holds the tendon firmly in place within its fibro-osseous tunnel. The typical injury mechanism involves a combination of forced wrist movements, specifically forced supination, fuller flexion bending the wrist forward, and ulnar deviation of the wrist. This particular, often quite violent combination of movements can directly disrupt the subsheath. We frequently see this after a fall on an outstretched hand, the classic fouche injury, or sometimes more repetitive, forceful movements you see in specific sports.
And the dynamic of it, the snapping itself.
Yes, the dynamic is quite telltale. The tendon typically dislocates or subluxes during supination, and then it snaps back, relocates with pronation. This recurrent friction, this constant sliding in and out of the groove, can then lead to secondary tendinopathy, more inflammation, and of course, significant pain over time. It often makes even simple rotational tasks, like turning a key or opening a jar, really unbearable for the patient.
It sounds like it's often tied to sports, but I recall you hinting earlier it might be more common than we once thought. Can you give us a sense of the epidemiology, the risk factors? Are we really seeing a shift here?
You're right to point out the sporting link. ECU subluxation definitely have a higher incidence in activities involving forceful wrist movements. Think golf, tennis, rugby, hockey, basketball. These sports often involve the very wrist positions, supination, flexion, ulnar deviation, to put that subsheath under strain and predispose it to injury. Historically, yes, it was considered quite a rare injury, but there's certainly a growing understanding that it may be far more common than we originally suspected, precisely because it's frequently misdiagnosed or perhaps underreported. For example, one study looked at tennis players and found that 1 in 18 experienced an ECU tendon injury. And significantly, 42% of those also presented with demonstrable instability. It's not rare in that group at all.
42%, wow.
Exactly. And what's particularly fascinating, and perhaps reflects modern life, comes from a recent study looking at an asymptomatic general population, people with no wrist complaints. This study found that a notable 6.6% of individuals exhibited ECU snapping, and 2.9% had ultrasound-confirmed subluxation or even dislocation.
In people without symptoms.
Correct. Within that 2.9%, about 13.6% were true dislocations, while the majority, 86.4%, were subluxations, so partial displacements. This research also found a statistically significant link between ECU subluxation or dislocation and engaging in more than 2 hours of daily hobby activity. It suggests a connection to the increasing use of modern tech.
Like phones and computers?
Precisely. Smartphones for messaging often involve ulnar deviation and pronation. Computers, prolonged mouse use, often with a pronated forearm. Game consoles, joystick control, often involving supination, all potentially predisposing wrist positions. This is quite a revelation, I think, because it means we might need to recalibrate our diagnostic lens. If 6.6% of the general population has snapping, then the absence of obvious trauma certainly doesn't rule out chronic instability.
All right.
We perhaps need to be more proactive in our dynamic assessment, even when symptoms seem vague or minor. It implies many cases might be missed or misdiagnosed initially and then eventually develop into chronic symptoms that finally bring the patient in.
That asymptomatic prevalence is indeed a revelation. It paints a much broader picture, especially with technology's impact. Now, when we consider surgery, I know you've mentioned Inu and Tamura's classification system before. Could you walk us through those different types of subsheath tears and, importantly, explain their clinical implications for surgical planning?
Yes, this classification is incredibly valuable when you get to surgical planning. It describes specific patterns of these fibroosseous sheath tears based on what was actually seen during surgery. It's definitely not a one-size-fits-all problem, and understanding these distinctions is paramount for a successful repair.
Okay, so type A.
Type A describes a situation where the fibroosseous sheath is torn from its ulnar side. So when the tendon is put back into its groove, it actually lies beneath the torn sheath, almost like a flap has fallen over the top. This was seen in 5 of the 12 patients in their original study. Surgical treatment for type A usually involves a reconstruction of the sheath. We often use a strip of the extensor retinaculum, or perhaps a fascial graft, to create a new, stable roof for the tendon. Direct suture repair is often difficult because the torn edges might be contracted or thinned out. So we're essentially rebuilding a stronger enclosure.
Okay, rebuilding and type B.
Type B is different. Here, the sheath ruptures from the radial wall. The key feature is that the torn sheath then lies in the ulnar groove beneath the tendon, like a piece of debris that's fallen into the pathway. 3 patients in their series had this type. Fortunately, type D is often amenable to direct suture repair. You can usually retrieve the flap and suture it back over the tendon, directly restoring the compartment's integrity.
More straightforward, potentially?
Potentially, yes. And finally, type C. This is perhaps the most intriguing. It's characterized by a detachment of the periosteum, the lining of the bone from the ulnar side, but it remains continuous with the fibro-osseous sheath. This creates an expanded, sort of redundant false pouch into which the tendon easily dislocates. This was seen in 4 of their patients. It actually looks quite similar to a Bankart lesion you see in recurrent shoulder dislocations, a kind of soft tissue pulling away from the bone.
Ah, interesting comparison.
Management for type C involves reattaching that periosteum, often using drill holes in the ulna, to effectively obliterate the false pouch and restore stability, essentially re-anchoring the soft tissues back to the bone. So, the crucial takeaway is that surgical success isn't just about fixing the sheath, it's about precisely identifying which of these 3 tear patterns you're dealing with. It dictates the surgical strategy.
Right.
It's the difference between a generic repair and a truly tailored anatomical solution. This directly impacts the likelihood of recurrence and ultimately patient satisfaction. If you misdiagnose the type, your repair might actually fail to address the underlying mechanical problem, leading to persistent symptoms.
Prof, differentiating these conditions really does hinge on getting the diagnosis right. Where do we start when a patient presents with that ulnar-sided wrist pain, particularly when trying to tease apart tendinopathy and instability in that initial consultation?
The absolute key, the pivotal role here, lies in careful history-taking and a really thorough physical examination. These are paramount in distinguishing between simple tendinopathy and an instability issue. Imaging provides valuable confirmation, of course, but the clinical assessment really directs your focus. It's like being a detective gathering the initial clues.
So what clues are you looking for in the history?
In the history, I'm listening for details like, was there a specific traumatic event like a foosh versus a more gradual onset? Do they describe a sharp pop or snap versus more of a constant aching? And critically, do movements like turning a doorknob, using a screwdriver, or any kind of twisting motion bring on their symptoms? That points much more strongly towards instability.
And the examination. Specific maneuvers.
For ECU instability specifically, yes, there are key physical maneuvers that can help elicit that painful snap. You can ask the patient to perform specific twisting wrist movements. Have them turn their hand palm up, supination that often causes the tendon to snap out of its groove. Then turn it palm down, pronation, which often causes it to snap back in. The palpable or audible snap, especially if it reproduces their specific pain, is highly indicative. You should also palpate directly over the ECU groove while they're doing these movements.
Feeling for that jump.
Exactly. 2 specific tests are particularly helpful here. The first is the ECU synergy test. You have the patient's arm resting, elbow bent to 90 degrees, and the wrist held in supination. Then, you ask them to radially abduct their thumb, move it away from the palm against your resistance. If this reproduces their pain in the ECU region, that's a positive test. The theory is that this maneuver causes an isometric contraction of the ECU, highlighting any underlying problem. It's quite a subtle test, but powerful.
Okay, the synergy test. And the other one?
The second is the ice cream scoop test. With the wrist held in pronation, ulnar deviation, and extension, the examiner palpates directly over the ECU tendon. Then the patient performs a scooping motion, mimicking, well, scooping ice cream.
Literally scooping.
Yes. Any palpable subluxation of the tendon during this action confirms a positive finding. A practical tip here is that patients often describe this feeling as their tendon jumping out. Beyond these specific dynamic tests, general palpation over the ECU tendon will help identify tenderness, any localized swelling, or that crepitus we mentioned, which can be present in both tendinopathy and instability.
That's an excellent breakdown of the clinical approach. Those specific tests sound incredibly useful in practice. Okay, so once we've done our clinical assessment, where do imaging modalities fit into this diagnostic puzzle? What are the strengths and, perhaps just as importantly, the limitations of plain X-rays, MRI, and ultrasound here?
Imaging plays a crucial supportive role, definitely, but it must always be interpreted in the context of your clinical findings. That's paramount. For all cases of ulnar-sided wrist pain, plain radiographs are an essential first step. They help us rule out other significant pathologies, distal ulnar fractures, maybe a hook of hamate fracture, which can mimic ulnar pain, or any significant arthritic changes, particularly at the DRUJ or the pisotriquetral joint.
Standard procedure.
The standard procedure. However, for isolated ECU tendinitis or subluxation, the X-rays are typically unremarkable. So a clear X-ray doesn't rule out an ECU problem. Moving on to MRI. Its value lies in identifying areas of increased signal intensity brightness, consistent with tenosynovitis or tendinopathy, basically showing inflammation or degeneration within the tendon. It also gives us insights into the integrity of the extensor retinaculum and, crucially, that ECU subsheath, which can be hard to see otherwise.
And dynamic MRI.
Yes, crucial point with MRI for ECU issues is the importance of dynamic imaging. Given that the ECU tendon's position is so dependent on wrist position, getting scans in both pronation and supination can really help assess the tendon's dynamic movement and potential subluxation. However, and this is a crucial caveat, one we must always remember, studies indicate that signal changes, signs of tendinosis, or even minor tears can be seen on MRI in a significant percentage, perhaps up to 75%, of perfectly asymptomatic wrists.
Really? That high?
Yes. It underscores the absolute necessity for imaging findings to always be correlated with the patient's clinical presentation and symptoms. We treat the patient, not the scan. An abnormal MRI without corresponding symptoms is often, a red herring.
A very important reminder. What about ultrasound?
Ultrasound has really emerged as an invaluable tool, particularly for dynamic assessment. It allows real-time visualization. You can actually watch the ECU tendon stability and movement during various wrist positions. That makes it exceptionally effective for diagnosing subluxation, as you can see the tendon moving abnormally.
You can see it happening live.
Exactly. Its advantages include accessibility, the ability to do a direct comparison with the other unaffected wrist, and it's good at visualizing inflammatory changes like tenosynovitis. Yet, similar to MRI, there's a normal variant to be aware of. Ultrasound exams in healthy volunteers have shown that up to 50% volar displacement sliding forward of the ECU tendon might actually be a normal finding during maximum supination, ulnar deviation, and flexion.
Half its width? Wow.
Yes. So again, clinical correlation is absolutely key. And dynamic ultrasound is often superior to static MRI for demonstrating true symptomatic instability. Finally, while they're primarily used for TFCC issues, the triangular fibrocartilage complex advanced orthography like MRA or CTA can also provide detailed views of the ECU and surrounding structures if there's a broader diagnostic question or if you suspect that TFCC is also involved.
That brings us to a final but incredibly important point on diagnosis. When we're faced with ulnar-sided wrist pain, it's rarely just one isolated thing, is it? What other differential diagnoses must we keep in our minds to ensure we're taking a holistic approach? And maybe, how do you quickly sort through them in your head?
This is indeed critical. Ulnar-sided wrist pain is notoriously complex, and having a broad differential diagnosis is essential to avoid missing other potential causes. Beyond ECU tendinopathy and instability, we must always consider, first, TFCC injury. This is a very common source of ulnar-sided pain, often presents with clicking, pain with rotation, maybe a sense of instability. The distinction from ECU often comes down to specific TFCC loading tests, and usually the lack of that specific ECU tenderness or snapping.
Okay, TFCC is high on the list.
Definitely. Then, distal ulnar fractures, even subtle ones, especially after trauma. Plain X-rays are key here, often revealing the cause straight away. Ulnar collateral ligament sprains, especially after trauma, to the ulnar side of the thumb or wrist. Tenderness is typically more localized towards the base of the thumb or the first web space. Lunotriquetral instability. This can also cause a clicking sensation and pain, but usually it's more centrally located in the carpus, and you might get a positive shuck test. Distal radial joint, DRUJ, injury. Given the ECU's role in its stability, DRUJ problems often present with pain and instability, specifically with forearm rotation, which feels different from tendon-specific pain. And finally, less common but crucial things like pisoticral joint injury, right at the base of the wrist, where those two small carpal bones meet, often painful with direct palpation or resisted flexion, or even a hook of hammy fracture, particularly if there's a history of trauma involving grip, maybe from a golf club or racket hitting the ground.
Quite a list to consider.
It is. But a thorough, systematic approach that encompasses these possibilities ensures we don't overlook other significant contributors to the patient's symptoms. It's about being a comprehensive detective, really, rather than getting tunnel vision on the most obvious culprit.
Right. Once we have that accurate diagnosis, the next big step is deciding on the most effective treatment strategy. What are the initial strategies for non-operative management for both ECU tendinitis and subluxation? And how do you perhaps tailor them?
For both conditions, yes. Our initial approach is typically conservative. The immediate priority is controlling the acute symptoms. That generally involves rest, regular ice application, particularly after activity, or if there's noticeable swelling, and the use of nonsteroidal anti-inflammatory drugs, NSAIDs, to manage the pain and inflammation.
The standard RACE approach, initially.
Essentially, yes. Now, when it comes to mobilization, especially for ECU subluxation, the goal is to keep the tendon in its proper groove and allow that disrupted subsheath a chance to heal. This usually involves splinting or casting the wrist in a very specific position, slight extension and radial deviation with the forearm held in pronation.
Why that specific position, pronation?
That position helps reduce the tension on the subsheath. It shortens the path of the tendon somewhat and reduces its tendency to slip out, to subluxate. The progression of immobilization can be quite instructive, and it often needs careful monitoring. We might initially try a short arm cast or perhaps a custom-made splint. However, if stability isn't adequately achieved with just a short arm cast, which you sometimes see in more challenging cases, or in athletes with high demands, then a long arm cast might be necessary.
Extending above the elbow.
Exactly. This cast is often applied with the elbow flexed to 90 degrees, and the wrist positioned in about 30 degrees of extension, radial deviation, and full pronation. The rationale for this very specific, almost exaggerated position is to effectively reverse that hypersupination mechanism of injury we talked about. It provides maximum stabilization and takes pretty much all the tension off the healing subsheath.
You mentioned a case study.
Yes, I recall a notable case, a collegiate basketball player with an acute traumatic ECU subluxation. She had a clear history of a fascia injury during a game, and on examination, a palpable, painful snap. We initially tried a short arm cast, but despite being immobilized, she could still actively sublux the tendon, just by trying to move within the cast.
Not stable enough.
Not stable enough. So that prompted a shift to an 8-week period in a long arm cast, in that very specific, fully pronated position that finally provided the necessary stability. This was then followed by a rigid wrist brace for another 3 weeks as she started transitioning back to activity. This whole conservative regimen allowed her a full return to sport within 11 weeks, with the added support of taping. It demonstrates that prolonged, correctly positioned immobilization can indeed be highly effective, even in elite athletes, provided you get good patient compliance.
That's a great example. And for persistent tendinitis, any other non-operative options?
Yes. For persistent tendinitis, beyond rest and NSAIDs, cortisone injections can be considered as an adjunctive therapy. They can help reduce localized inflammation around the tendon. However, we always have to weigh the benefits against the potential risks: tendon weakening, maybe skin atrophy. They're certainly not a cure-all. Surgical intervention for ECU tendinitis itself is actually rarely needed. It's typically only considered if symptoms persist despite appropriate and prolonged non-operative management. In those cases, a surgical debridement of the tendon and perhaps a release of the tight sheath might be performed to decompress the inflamed tissue.
Okay, that makes sense. But when do we reach the point where surgical intervention becomes necessary for the instability, for the subluxation? And what are the different operative techniques tailored to those specific subsheath tear types you outlined earlier?
Surgical intervention is generally reserved for cases of chronic ECU subluxation, meaning it's been going on for some time, particularly when traumatic insufficiency persists despite an adequate trial, a good long trial, of conservative casting, or simply when patients remain significantly symptomatic and are unable to return to their desired activity levels or sports.
So failure of conservative treatment or high demand?
Exactly. For instance, if you have an athlete whose career is potentially on the line and they've failed extensive conservative therapy, surgery becomes a much more appealing option. And the surgical approaches are indeed tailored to the specific type of subsheath tear, using that Inouye and Tammer classification, which really underscores why knowing the type is so vital beforehand.
Right. So for an acute tear.
For acute tears, where the torn edges of the subsheath are clean and look viable, a direct repair is often feasible. You essentially suture the edges back together, reconstructing the natural anatomy.
And for chronic tears, or that type A.
For more chronic tears or extensive disruptions, like the type A lesions where the sheath is torn from the ulnar side and lies over the tendon, reconstruction is typically necessary. This involves creating a new stabilizing structure. Often, we use a strip of the extensor retinaculum itself. It's folded or routed to create a new, robust roof over the ECU tendon, effectively rebuilding the compartment's integrity. It's about providing long-term stability where the original structure is too damaged or attenuated for a simple direct repair.
Okay. Using local tissue. And type C, the false pouch.
For type C lesions, characterized by that detachment of the periosteum forming the false pouch, the management involves periosteal reattachment. Here, the detached periosteum, which is still continuous with the sheath, is reattached firmly back to the ulna, often using small drill holes or suture anchors. This effectively obliterates that false pouch and restores stability by re-anchoring the sheath directly to the bone.
And are there other surgical variations?
Yes. Other variations in technique can also include deepening the ECU's groove in the distal ulna. This provides a more stable, anatomically defined bed for the tendon, helping to prevent future subluxation. Almost like creating a deeper valley for the river to flow through, if you like.
Makes sense. And after surgery, what's the typical protocol?
Following any of these operations, the post-operative protocol is critical for success. It typically involves a period of immobilization for about 6 weeks, often in a long arm cast with the elbow bent to 90 degrees and the forearm in neutral rotation. This provides the necessary stability for the repaired or reconstructed structures to heal solidly. Crucially, we emphasize a prolonged restriction of vigorous athletic activity for an additional 3 months after the cast comes off.
3 more months.
Yes, this extended period is absolutely vital. It ensures adequate healing, allows the tissues to mature properly, and helps prevent recurrence of the subluxation from loading it too early. Surgical series have reported high rates of good to excellent results, sometimes as high as 82% in groups treated with retinacular slings, or significant improvements in pain scores with groove deepening and sheath reattachment. It really underscores the effectiveness of these tailored surgical interventions when they're indicated.
That clear distinction between surgical approaches based on tear type is so important. It really is a bespoke solution. Now, post-immobilization, whether that's conservative or post-op, comprehensive rehabilitation is obviously paramount. Could you outline the structured rehab protocols, particularly highlighting the principles behind specific strengthening exercises?
Absolutely. Rehabilitation is truly the cornerstone of regaining full function and, importantly, preventing recurrence. Once the immobilization period is complete, the focus shifts squarely onto regaining range of motion and strength. This is usually done through a structured physical therapy program. Supervised exercises are crucial here. They address any stiffness that might have developed during immobilization and facilitate the reacquisition of wrist strength and full movement. For example, after the cast comes off, a rigid wrist brace might still be worn for perhaps another 3 weeks as the patient progresses through their exercises and regains abilities. It gives a sense of security and continued support during that vulnerable early phase.
And the strengthening itself, you mentioned isometrics.
Yes, for strengthening, particularly focusing on the ECU and also the pronator quadratus muscle, isometric exercises are highly effective. They help stabilize the wrist without putting undue stress on the healing tissues. The core principle here is to engage the muscle without significant joint movement. This allows for strength building and stabilization. Now, for a detailed step-by-step visual guide to these specific isometric maneuvers, we highly recommend you check the show note. There'll be a link to a demonstration video there.
Great. A visual guide helps.
Definitely. But remember, the core principle is isometric resistance, not large wrist movements. Briefly, these exercises typically involve things like isometric resistance to radial deviation, strengthening the ECU's role as an ulnar deviator, isometric resistance to extension and pronation, targeting its role in those combined movements, isometric resistance to ulnar deviation and flexion, further challenging it in different planes, and isometric resistance to pronation, which engages the pronator quadratus, a muscle that synergistically aids in DRUJ stability.
Okay, targeting specific actions isometrically.
Precisely. And it's vital to emphasize to patients that they should stop any movement that causes extreme pain and consult their therapist. The key is to feel the muscle working strongly in the forearm, but with very little actual movement happening at the wrist itself.
Got it. Any other rehab techniques? Kinesiotaping?
Yes, beyond exercises, kinesiotaping can be a really valuable adjunctive technique. It can help with pain relief and provide support, especially as patients are transitioning back to activity. For instance, you can use an I-strip application to provide direct support to the ECU tendon. You start the anchor with no tension, just distal to the base of the fifth metacarpal, where the ECU inserts. Then apply about 35% tension for the middle part of the tape, with the wrist held in slight extension and ulnar deviation to offer some mechanical stability. The tail should have no tension. Another approach uses a Y-shaped piece of tape. You anchor it with no tension on the volar ulnar aspect of the wrist. Then apply each tail with about 35% tension, finishing with no tension at the ends. The tails of the Y-strip should be positioned proximal and distal to the ulnar styloid. This helps to sort of offload and stabilize the ulnar side of the wrist, reducing strain on the ECU during dynamic movements. These taping techniques can provide crucial pain relief and proprioceptive feedback, especially as patients get back to full activity.
Prof, the finding you mentioned earlier about ECU snapping in asymptomatic individuals during our deep dive was truly intriguing. What are the broader implications of this sort of unseen burden, and how might it be connected to modern life and the cases we're actually seeing in clinic today?
It's a compelling observation, isn't it? Recent research does strongly suggest an increasing incidence of ECU snapping in the general population, even in people without active wrist complaints. And there's a powerful hypothesis linking this directly to the widespread use of technological devices. Think about it. Smartphones, where messaging often involves sustained ulnar deviation and perhaps pronation. Computers, with prolonged mouse use, often in a slightly pronated, extended wrist posture. Game consoles, with joystick manipulation that frequently involves repetitive forearm supination and ulnar deviation.
Those repetitive movements.
Exactly. These activities place the wrist in positions that we know can predispose to ECU issues. They create repetitive, low-grade strain on that subsheath day in, day out. The implication here is significant. Many cases of ECU pathology might initially be missed or misdiagnosed because they're asymptomatic, or perhaps the symptoms are really vague, just a sense of discomfort or fatigue. This could lead to the gradual development of chronic pain and instability over time.
So it could be building up silently.
Potentially. This hidden prevalence suggests we might be vastly underestimating the true scope of these conditions. And it means we probably need to be asking more specific questions in our patient histories, even for seemingly minor complaints, to try and uncover these developing issues earlier.
That's a powerful point about the silent progression and the need for maybe a recalibrated approach. Thinking about both conservative and surgical options, are there ongoing debates about the optimal timing or type of intervention, especially for active people, athletes? And what do we actually know about reported outcomes?
Oh, there absolutely is an ongoing clinical controversy regarding the optimal timing and type of intervention for ECU subluxation. It's often debated whether a prolonged conservative approach versus perhaps early surgical intervention provides superior long-term outcomes, particularly in those high-demand active individuals and athletes where, time to return to play is often a major factor.
The pressure to get back quickly.
Precisely. Some studies suggest that conservative management can be highly effective. For example, one study followed 5 elite tennis players who had complete ECU subluxation after an acute injury. They were treated with short-arm cast immobilization for 2 to 3 months with the wrist slightly extended. All 5 patients saw their pain and instability resolve, and they were able to return to their previous level of play at an average of 5 to 6 months after diagnosis. This suggests that in acute cases, careful conservative management can yield excellent results, provided the patient is compliant and the immobilization is truly effective. The rationale being you allow natural healing without the risks of surgery.
So conservative can work well. But surgery?
Conversely, yes, surgical series have also reported very high rates of good to excellent results. For instance, one group of 28 patients treated surgically with ECU stabilization using a radially based sling of the extensor retinaculum wrapped around the tendon. 82% reported good or excellent outcomes at a mean follow-up of 23 months. Another study looked at 21 patients treated surgically with a slight deepening of the ECU groove, about 2-3 millimeter, and reattachment of the ulnar side of the subsheath using suture anchors. At a mean of 31 months later, their motion was maintained, grip strength was comparable, importantly, no patients noted snapping, and their pain scores significantly improved.
So both approaches show promise.
They do. The debate often centers on that initial decision for acute traumatic instability in athletes. Some argue that early surgical intervention should be the first-line treatment to ensure a rapid, predictable, and stable return to play, minimizing the risk of developing chronic instability and having a prolonged recovery. Others prefer to exhaust conservative options first, due to the inherent risks associated with any surgery.
The core question being,
The core question becomes, is it worth the surgical risk for potentially a faster, more guaranteed return to high-level activity? Or is conservative management potentially just as effective long-term, even if it might take a bit longer? There's no single right answer for every patient. It's a careful balance of their specific goals, the injury's chronicity, the extent of instability, and their tolerance for risk.
that nuanced picture of outcomes really highlights the complexity, and it leads me to another thought. Is it always clear whether conservative immobilization actually allows for true anatomical healing of the subsheath? Or could it be more palliative, just reducing symptoms? And how does that inherent variability in ECU tendon mobility factor into making clear recommendations for surgery?
These are excellent questions. They get right to the heart of the nuance in diagnosis and treatment, and they are definitely points of ongoing discussion amongst hand surgeons. It is often unclear whether cast immobilization truly allows for full anatomical healing of the ECU subsheath, leading to a complete structural repair with restored tensile strength, or if its primary effect is simply palliative, meaning it reduces symptoms by preventing further subluxation, without necessarily achieving full anatomical restoration. Perhaps it just allows scar tissue to form, which merely stabilizes it enough for function, but isn't a true, new repair. This is a point of ongoing discussion, as long-term studies with advanced imaging are still needed to definitively answer that question. Furthermore, there's that inherent variability in ECU tendon mobility among individuals. This can exist just as a normal anatomical variation. Some people naturally have a slightly more mobile tendon without any symptoms at all. Or it could be the result of prior, perhaps subtle, unrecognized injuries that have led to some thinning or stretching of the subsheath over time. This variability can sometimes make clear recommendations for surgical intervention quite challenging. When a patient presents with snapping, discerning whether it's a pathological instability that genuinely warrants surgery because it's causing pain, functional disability, and potentially progressive damage, or if it's simply a normal, though perhaps more pronounced, variant of tendon movement. Well, that requires incredibly careful clinical judgment and correlation with the patient's actual functional disability and pain levels.
This is not just the snap itself.
Not just the snap itself. It underscores why a thorough clinical examination, coupled with dynamic imaging, is so vital to prevent unnecessary procedures, but also, conversely, not to miss a genuine problem that really does need intervention. It truly has to be a patient-by-patient assessment, considering their specific symptoms, their demands, and the objective findings.
This deep dive has been incredibly insightful. It's really shed light on a condition that, as we've learned, might be far more prevalent than we traditionally thought, especially with, evolving lifestyle factors and our growing understanding of dynamic wrist mechanics. Before we close, I want to leave our listeners, the medical professionals, with a final provocative thought. Considering this evolving landscape of risk pathologies, particularly with the rise of technology-related injuries and the often subtle presentation of ECU issues, how might a more proactive and dynamically informed diagnostic approach to ECU problems not only improve individual patient outcomes, but also fundamentally reshape our collective understanding of chronic, ulnar-sided wrist pain? Something to perhaps ponder. #tagoutro. Well, this deep dive into ECU tendon problems has truly spanned the spectrum, from its intricate functional anatomy and dynamic stability through the varied pathologies of tendonitis and instability, and covering the nuances of clinical assessment, advanced imaging, those tailored conservative and surgical treatments, and the vital importance of precise rehabilitation. We've covered a tremendous amount of ground. I really hope you feel better equipped now to tackle these often complex cases in your own practice. We trust you'll integrate these insights, helping you achieve more accurate diagnoses and effective management for your patients. And if you found this discussion valuable, please do consider rating and sharing the Deep Dive Ortho with your colleagues. It genuinely helps us continue bringing these detailed discussions to other medical professionals like yourselves.
It's certainly been a privilege to share these insights and contribute to such an important discussion. Thank you.
And thank you for your exceptional insights and expert guidance throughout this really complex topic. Until our next deep dive, keep learning and keep asking those crucial questions.